It's an honor to be here. I feel a little bit at a disadvantage as a radiologist, and that I should be explaining some radiology to have you understand my perspective. I admire my esteemed colleague for his perspective, and now I would like to give you a radiology perspective on the benefits of MRI and the use of breast MRI in neoadjuvant chemotherapy patients. I will say that at our institution, we perform breast MRI on all patients undergoing neoadjuvant chemotherapy to start. Now, I have no disclosures. Okay. The first thing you should understand is that not all breast imaging is the same. It is very much dependent on high quality and the operator, the person who is performing the examination. This is not a test where you have the same quality for everybody. You have to have high quality breast imaging. You also have to appreciate that there are differences in breast tissue density. And breast tissue density is categorized by 4 separate categories: fatty replaced, scattered fibroglandular tissue, heterogeneously dense, and extremely dense. And dependent on the density, the sensitivity of the mammography will vary from as high as 95% in the fatty breast down to as low as 45 to 50% in the extremely dense breast tissue. The other thing you should be aware of is that ultrasound is highly operator dependent. The breast can be very small or very large, and when you look at the breast, you have to cover that whole area. And it's very easy to miss certain areas with ultrasound. It's been shown in the Akron 666 trial that up to 25% of lesions, masses, were missed by one of the ultrasound technologists or radiologists. Here is an example of one of the limitations of mammography. This is a 77-year-old woman with a palpable left breast mass. You cannot see this mass on mammography. Ultrasound was done and shows a 3.5 centimeter mass. Now, if she went simply for a lumpectomy, we would have missed this is the index tumor, all of the additional lesions in her breast with multicentric and multifocal disease. These would not be treated with chemotherapy or radiation therapy. This would likely result in an early recurrence. Now this MRI changed her management to go for neoadjuvant chemotherapy. On the other hand, this woman has very fatty replaced breasts. It's very easy to see her through her breasts. And we actually do not see the lesion on this breast, but we see it with MRI. So although most of the time we identify cancers with fatty breasts, you can see that the MRI was required in this patient. We know from studies that MRI has been proven superior to physical exam, ultrasound, and mammography for the assessment of tumor response following neoadjuvant chemotherapy. And a study by Rosen et al. Showed that MRI had the highest correlation coefficient with histology compared to physical examination. We have, as my illustrious colleague said, meta-analysis looking at pooled sensitivity and specificity, and we know that MRI has the highest sensitivity and specificity, but it's still not perfect. We know that it underestimates disease in 17%, and it underestimates disease in 47% and underestimates it in 17%. And we really know that it's best in assessing response compared with certain histologic subtypes and with triple-negative cancers. We also know that if a lesion disappears at contrast-enhanced MR imaging after chemotherapy, we cannot draw conclusions. And here is an example of a 45-year-old woman with pre-treatment MRI showing a large area of mass and non-mass enhancement that becomes much less at post-treatment MRI, and yet at histology we see that there was a 5.5 centimeter area of residual tumor. So we know there are limitations from MRI. But we also know that MRI is the best way at predicting pathologic response compared to no MRI, and it also helps predict whether we need a mastectomy or not. We can really benefit from this as the most sensitive test. We also know from the Akron I-SPY trial that tumor volume is very helpful at predicting complete response and a recurrence-free survival. And this is from the radiology article showing the response with the reduced functional tumor volume, which predicts high levels of complete response and recurrence-free survival. The last thing I want to give you is that MRI gives us functional biomarker information. And we know that looking at the lesions, if they have high washout, peak enhancement, we know that these correlate with poor disease-free survival. So this information is very helpful for functional assessment. And this kind of example where we see the washout with this red enhancing lesion with washout really correlates with very poor prognosis. Monica Morrow published the study in Annals of Surgical Oncology in 2015 talking about the improvements in systemic therapy and the available of selected targeted therapy that increased the rates of pathologic complete response, but that there was no corresponding increase in the rates of breast conservation surgery. And looking at their group of 111 breast conservation surgery candidates showed that in those patients that showed partial response to chemotherapy on MRI, 75% underwent breast conservation surgery, and in 91% they were successful. So MRI correctly identified the breast conservation surgery candidates 88% of the time. So this, she argued, would be a helpful way to lower the mastectomy rates and predict best breast conservation surgery candidates. And here is an example showing the marked response of on chemotherapy and predicting who would succeed with breast conservation surgery. So in summary, MRI is more accurate than clinical assessment, mammography, and ultrasound. It also is a biological marker. It helps provide prognostic information and predict pathologic complete response best of all the imaging tests. Remember that radiology is very dependent on quality and high operator-dependent function, so that some of these studies where we compare directly with ultrasound, we have to think who is performing the ultrasound and be aware of the quality of imaging that you are obtaining. MRI gives us the whole picture with high quality. And I would leave you with a question. If you were treating your mother or your sister, what test would you want? Thank you.
Thank you very much. I would like to thank all the speakers.